Okay, Dr. Sievert, can you hear me?
Good morning, everybody, and welcome to CVC Frankfurt.
Okay, this is a live case session of LAAO Appendage, and I'm Ping-Han Lo from Taiwan, and my co-moderator is Dr. Hong Yu Lim from Korea, and we have a panelist, Dr. Paul Lim Chen, Dr. Garot from Germany, from France, Dr. Raffel from Australia, and maybe Dr. Sievert, you can tell us about this case.
So let me first introduce our team. Judith Stefan is here doing the TEE. Then we have Mirjana, Celina, and Judith helping us with this case. Can I have the slides of the case presentation, please? This is an 81-year-old male patient. He has a history of paroxysmal atrial fibrillation. Anticoagulation is contraindicated due to recurrent gastrointestinal bleeding of unknown cause. He also had a TIA in 2017. In October last year, he got an aortic valve implantation, a TAVI with a core valve. He has hypertension and mild mitral stenosis and regurgitation, which is not significant clinically. EKG currently has sinus rhythm. Risk scores are just VAS score is 5 and TAS-BLED score is 3. So we already have the TE probe in, and Judith is ready to show what she has seen there. Judith, please.
Good morning, everybody, or good afternoon to where you are. So we have a very long atrial appendage here. It's currently thrombus-free. The diameters of the landing zone are about 2 centimeters at 67 degrees, and at 135 degrees, we have also almost 2 centimeters. There seems to be a slight chicken wing anatomy and quite a few lobules in the left atrial appendage.
Are there any questions regarding the indication or the imaging of TEE from the panelist?
No, I think for this patient is with high chest score and also have a breathing risk, and actually had the clinical breathing, so it's a very good indication. I think that the LAAO is definitely will help him. So what kind of device will you use?
We didn't, well, we are supposed to show a Watchman Flex, but we have all other options available. So we will make the final decision when we have done the angiography of the left atrial appendage. So far, I have a 6 French sheath in the groin, and I will now exchange for the transeptal sheath for the transeptal puncture. Let me introduce the wire here, going to the right atrium. We will use the SL1 for the transeptal puncture. Yeah, regarding ILF, I followed the discussion during the break, and we have the same limitations here in Germany as most of you have in the other countries. That is, the indication is limited according to the study results and according to the guidelines to those patients who have contraindications against anticoagulation. So we need further trials to change this. And as you know, these trials are underway with the Champion trial, for example, where we will test LAA closure against NOACs. And I think this will change the situation, but it will take a couple of years. So now the sheath is in the superior vena cava, and I will insert the needle. Judith, I will need the long axis bicable view of the septum and thereafter explain. He needs more sedation, Selina. Okay. So the needle goes up. I keep that distance of about a finger between the hub of the dilator and the needle. I go to 6 o'clock or 5 o'clock with the arrow on the needle. And now I'm coming down.
This
You see
patient
the
also has a
tenting on the
device.
Yeah, TAVI was implanted back in October last year. You see the tenting on the TEE of the septum secundum right there, exactly. I'm slowly coming down. I rotate more to 6 o'clock. I want to puncture in the inferior segment of the septum, and I would like to go a little bit more posterior inferior, that is where we want to puncture. Can you give a little bit more gain on the right side especially? Okay, you see the tenting, I think
Yes,
that
yes.
should be a good position. So I puncture with the needle. I'm through. I advance. Let me focus here. So now I keep the needle in place and advance the dilator with the sheath. And now I keep the dilator and advance the sheath only over the dilator. I'm pulling out the dilator and the needle. At this time, I will give heparin. We usually give 10,000 units of heparin, independent from body weight. But if the procedure takes longer, then we check ACT, but not routinely. Because with 10,000, we are almost always in the range where we want to be. So next step is to go to the left atrial appendage with an angled pigtail catheter. I think he needs more sedation. Huh? So I like to use the 4 French angled pigtail because the tail is smaller than with the 5 French. This patient has a very long pulmonary ridge. So the ridge between the appendage and the pulmonary vein is very long. So this is probably the pulmonary vein. And I see this on TE as well. So I will have to pull back
Horst,
and go more.
Horst, do you use CT at all to plan what device you're going to put in beforehand, or do you just use angiography and TOE?
We just use angiography and TE during the procedure. We don't even do a TE before.
Yeah.
Let me check where we are. So this is appendage. So I always go to, be careful, I rotate the X-ray. I always go to areocaudal because this gives me the largest diameter, and that's what I want to know, the largest diameter of the landing zone. Oh, I forgot to mention, you see this here, let me take a cine. You see that this patient also had a paravalvular leak after the TAVI, so this was occluded a couple of weeks ago. So you see that is an AVP2, which is at the side of the frame of the TAVI valve. So let's try to get more into the appendage here. I pull back the sheath a little bit. No. I'm in an inferior lobe. I would like to go to a more cranial lobe, anterior lobe. Okay. Okay. Now let's take a sinner. This is huge, huh?
It's huge.
This is huge.
It doesn't look like.
The question is, yeah. The question is always where to measure. And there are always differences between CT and TEE and angiography. But the main problem is that we don't know where to measure. This is the problem. That's why we are looking for other techniques which are independent from size and shape of LAA closure. These are, as you may know, under development. So for example, this is probably the level of the circumflex where we want to start. And then we probably should go up to here. This would be too big for any of the devices.
Huge.
Yeah. So not sure whether we can close this appendage here. So we will probably be able to close only part of it. That will be a very interesting case. So this would be too big. And then we could also go for this area here. And actually, these are two lobes, right? One lobe is here. And another lobe is here. So even this small upper lobe here has a diameter of, what is that, 27. Yeah, too big for anything. Let's try with the biggest watchman we have and see how it goes. I'm assuming that there will be a residual leak, which then needs closure later on during a second procedure. Can I have the watchman sheath, please?
Can you let the cine go again? Let me have a clear
Yeah.
looking at it.
Let me just store this one here. Okay. Okay, watchman sheath. Huh? Yeah. There's one area which could be borderline for the. So the biggest watchman flex is 35. I didn't expect that from the TEE, this problem.
Sievert, you are planning to insert the biggest one.
Yeah, the biggest one is 35. Yeah.
35.
Yeah. So there are different techniques to exchange for the big sheath, and I prefer to exchange over an Amplatz extra stiff directly into the appendage. It's falling down into the small lobe again. Yeah. Okay, so here we are. Important is to use the Amplatz extra stiff with 3 centimeter soft tip and J at the tip. And then it forms like a pigtail, as you see. And this is, in my experience, pretty safe. More safe than exchanging in the pulmonary vein. But this is always a debate at conferences and live cases. So most of the other operators, as you know, exchange in the pulmonary vein and then pull the sheath back and let it drop into the appendage. Yeah. I think both techniques are safe, so it's not really that one is superior to the other one. So I'm removing the transeptal sheath now. So if we have a residual leak here, this will be when the first Watchman flex, where I will go ahead and close the residual leak later on. This is residual leaks are very rare with the Watchman flex. We will see. So this is the double curve. Yeah, go ahead.
What would you use to close the leak, residual leak, Horst, if it's a small leak?
Most often we use the AVP2.
Okay.
Occasionally, if it is more like oval shape, then occasionally we use the AVP3, but that's rare. I have a problem in the groin here. Let me check what's going on. Oh. Be careful. Okay. Interesting, huh?
Yeah, it's a bit tortuous there.
Yeah. Julia, maybe we need a bigger sheath, probably the 16 French sheath. Yeah. But okay, good. I hope that I'm still in the appendage.
It's still there?
Yes, I am. Mm-hmm. Good. So this shows that the sheath diameter is important for LAA closure. So downsizing is a goal we should not forget when we develop new devices. Okay. So with the Watchman flex, I don't have to go too deep into the appendage. But in this case, because of multiple lobes, I will do this. So if this would be a regular appendage, then I could just go to the orifice and then advance the device from there. Let me go to the same projection we had before. That was REO 33 and quarter 24.
We don't have any experience about the Watchman flex. So maybe during the procedure, you can tell us more about the difference between this device and the original Watchman.
Yeah, I will do. So one difference is, the most important difference probably is that the distal end of the device is closed, whereas with the old Watchman, it's open. I don't have a non-sterile device here that didn't arrive on time, but I can show you the difference on fluoro. So, and then also it has more struts, it has more hooks, and the larger part of the device is covered with fabric. Also the proximal hub, where it's attached to the delivery cable, is covered more or less completely by fabric. So I think these are the major advantages. So I go to very distal end, which is the old technique for the Watchman, for the old version. Can I have the 35?
You have only the super stiff guy wire in appendage.
No, it's extra stiff. It's extra stiff, not the super stiff. The super stiff is really too stiff. So it's important to use the Amper's extra stiff and with a 3 centimeter long tip. There's also another version, I think with a 9 or 10 centimeter long tip, and that is not good. So it's really only this particular wire, and it behaves like a pigtail. And that's why it's safe to do it this way. So as you know, the Watchman comes preloaded, so I don't want to push it out here. What's that? I don't want to push it out, but I can just show you the distal, very distal tip. Can you focus? So you may be able to see here that the distal tip is closed in contrast to the old Watchman, where it's kind of open frame. This one is closed like a ball, and this makes it much more atraumatic as with the old version. Okay.
Does it deploy similar to the amulet, Horst?
Yeah,
in the way you
in
do
some
it.
Way, yes,
yeah,
because you can form a ball like with the amulet.
Yeah,
and also you can because it's atraumatic, you can push this ball
around,
towards the Okay. I'm rotating a little bit counterclockwise to keep it in the superior lobe. So now you see the distal marker, which was not present in the old version. It's now at the distal end of the sheath.
Yeah.
And now I pull back the sheath and connect. I pull back the sheath and connect it with the delivery catheter. Now they are connected. Let's do a little puff here. Okay, so now I will expose the device partially, and I push it out until the diameter of this little ball is twice the diameter of the sheath, like this.
Okay.
Okay.
Yeah.
So at this point, I could advance the entire system or can pull it back without problem. I think I'm close to the distal wall of the appendage, so I will not push it further out. Also, it starts flexing down, which also shows me that I'm in contact with the wall of the appendage. Let's do another cine here to confirm that. Yeah. Okay. So now I will slowly deploy it. I will do this as slowly as possible. Okay. I'm sure that I did not cover the inferior lobe. Yeah, as expected. So,
Dr. Sievert?
yeah.
Why don't you landing the device more proximal?
Yeah,
I think that the landing zone is too deep.
I could try, but
Yes.
the problem is that the diameter will be too big, probably.
But the compression is too over compressed.
Yeah, agree. So that's what I do now. I will measure the compression here and see whether it makes sense to pull it out a little bit more. I fully agree. Wait. Yeah, 27. So we have a little bit room, so we can recapture it and pull it out a little bit more, and then see what happens. Okay. So I will retrieve it. And start deploying here. Okay. Let's go to a different angulation here. Okay. I'm still not covering the inferior lobe. Yeah. Thinner. No, not completely, huh?
Yeah. A little bit proximal landing would be better.
Yeah.
Yeah. It still
But
too deep.
you see that at the roof of the appendage, the diameter is also larger. So if I pull more, I probably will not be able to close this completely. But let's measure here. Okay. We still could pull, yeah. Okay, let's do that. Okay. Yeah, now as expected, now I have a bigger gap, more cranial. What do you think? Should I pull even more? There's still a big gap at the inferior edge. This does not change.
It looks like the snowman, so the compression is too high. So I think the landing zone is too still deep.
A bit more.
You mean I can still pull it more proximally? Is that what you say?
Yeah.
Yeah.
Yes,
Yeah.
I also think
This is maybe to that shoulder.
Yeah.
Yeah.
Yeah. Look at the TEE. You see a gap there of about 1 centimeter, right?
Yes.
How much is that? Yeah, 5 millimeters, 5 millimeter gap. Yeah. So the question is, we could also think to place it more distally and then use a second device for the inferior lobe.
Yes.
Or we can try it. Yeah. So these are the two options. Huh? We can reposition this device as often as we want. So there's in fact no limit. Mm-hmm.
Mm-hmm.
Still enough compression.
Yeah.
Yeah. Let's pull a little bit more. So by the way, talking about different devices here, so the amulet also would have the same problem. An option would be to use the lumbar device with a special design. Still enough compression. I pull a little bit more. Ah, I need contrast, okay. Right. Still more. We will see on TE the big second lobe, which definitely will need a second device. Definitely. There's no way.
Put on the color flow signal on the T.
Yeah, we can check with that. Let me pull further out. I think I didn't really change the position when I pulled
time, yes.
last time. Yeah, it's still the same. Still no change. I think it's distally compressed. No, it didn't change. Let me do this again. So the reason why you can reposition as often as you want that they also change the design of the hooks. So with the old Watchman, I mean, I repositioned the old Watchman also as often as I wanted, but this was against the IFU. Still no change.
Yeah.
So, but with this one, these hooks are a completely different design, so they can be repositioned as often as you want. Now it's in a different position.
Different position, yes.
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 Yeah, that's. Yeah.
Little bit.
No, even more, huh?
Yeah.
Yeah.
Tricky.
Oh, now it's out, huh? Let's start from here. Different shape now. Huh? No, it's not. It's not compressed enough.
Yeah.
It's not. Let me go for a different projection. I think we don't have enough compression, but let's measure.
Yeah, much better.
Yeah, but compression is not enough. Let's see. $30, okay, that would still be okay.
Yeah.
Let's store this, so. Okay. Did I do an angio in this projection? Right.
Much better.
But still a lot of residual leaks. But I think I cannot pull it more.
Yeah.
And also so, and I think on the inferior side, there's still a big gap of a couple of millimeters. Yeah. Let's look on TEE. So as always in 40 degrees, it looks nice. So that's the view. If you want to have a good result, look at 40 degree. But when it comes to 135 degree, then it probably will not look as nice. Show me the gap.
Trying to find it again.
Yeah.
Working on it. It was a lot less than before, but there it is. Hold on. Let's scroll back. There.
That is.
Right.
Okay.
Yeah.
But that's nice, yeah. I'm sure that we will be able to close this later. I will not do this at the same time here. Let me do a tuck test before we proceed. It looks stable. So we will need, we see at least two leaks. One is the inferior leak, which is seen on TEE, and the other one is at the roof of the appendage.
Yes.
Yeah, which I think both of them will be not too difficult to close later on. So I tend to leave the device as it is for now. But let's look at all different echo views before we make that decision. Here it looks nice. So please keep this image in your memory.
At 135 degrees, that's a small gap.
Yeah, it's a big gap. It's a big gap. It's a big gap. So this is definitely something which is not the final solution, because with a gap, according to the old Protect AF protocol, we continue with anticoagulation unless we have a leak which is smaller than 5. This one is for sure bigger than 5. So this will not be the final solution for this patient here.
Mm-hmm. So Dr. Sievert, you may wish to close the gap in the future, but what kind of device will you use?
This will be, well, the inferior lobe, which is pretty big, that could actually be a second Watchman. And the cranial defect, what you see on fluoro, that's something for an AVP2 or maybe 2 AVP2 side by side.
Okay.
Yeah, okay.
And Horst, what's your preferred antithrombotic strategy, assuming you've closed all the leaks?
Then we would give Plavix for 3 months and aspirin for 6 months, and then stop everything unless the patient has other reasons to get some treatment. But in this case, we will. I mean, he's currently. I think he's currently taking something in a low dose, so we will continue with that. A NOAC with a low dose. Yeah, until he comes back. And the question is when to do this. I mean, the longer we wait, the more secure is the old device healed in. So I would like to wait at least for 2 months, maybe more. So this will depend upon what kind of anticoagulation you can take over that time. If we can keep him longer on medication, then I would like to wait for 4 or 6 months. This would be optimal. You see the color flow with the gap. Okay, good. So I think I will release it here. Okay, still in place. And no change, obviously no change regarding the leak. This would be very unlikely that this changes now.
Okay, as you know, there are huge differences in LA appendage size between the TEE and the angiography. Why these huge differences in this case?
Well, I mean, imaging was difficult in the 135-degree view. We had very good images in 40-degree, but 135 was difficult. But I mean, the differences in measurement between diameters between angiography, TE, and CT, this is really because it's difficult to compare the location where you measure. But we couldn't really see this additional lobe on the TE. So this was the main problem here. But I mean, even if I would have seen this before, I would have proceeded in exactly the same way. So there would be no difference.
And I think in this case, the long entrance and the long ridge was misleading as in our first measurements.
Yeah, yeah, absolutely, yeah, okay. Yeah.
Which imaging modality do you usually use when you choose the device size? Which imaging modality do you prefer?
Yeah, that's a good question. So I go for the largest diameter in any imaging technique. So if the largest diameter is measured on angiography, then I take that. If the largest diameter is measured on TE, I take that. The good thing with the Watchman Flex is that it is so much forgiving regarding the size. So in theory, you could close every appendage with the largest device because there's no harm to overcompress the device, which is also a difference to amulet. With the amulet, as you know, when you oversize, actually there's a risk that it is kind of squeezed out. This is not the case with the Watchman Flex. And so there's a wide overlay between the different sizes. And you could use the 35 for even the smallest appendage. The only disadvantage then is that it becomes longer and longer. So you need a long appendage in order to use the 35. But when we can look here at the sizing chart from the Watchman Flex, for example, the 35. So this is the, can you see this on the screen? Yeah. Please zoom in, Jürgen. Yeah, okay. So this is the landing zone. And you can, for example, choose the 35 device between 24 and 32 millimeters. This is according to the IFU. And, but in fact, you can also close a 19 millimeter appendage with the 35. The only disadvantage is then it becomes longer. So you need a longer landing zone when you want to use a bigger device.
You didn't check the LA pressure before implantation or sizing. So
oh yeah, good point.
Do you think the LA pressure is not important?
Yeah, it is important. I forgot to mention this. We want to have an LA pressure higher than 10. Actually, in this patient, it is 10 or 11 now, 14. Because when you have lower pressure in the appendage than 10, the measurements are about 2 millimeters smaller. So you could either add these 2 millimeters or make sure that the patient is well hydrated before you do the procedure. So we always, when we do these procedures in the morning, there is no point. But when we do this in the afternoon or in the evening, we make sure that the patient has enough fluid on board before he comes to the cath lab. If you see that the appendage, the LA pressure is too low, then the question is what, at the time of the procedure, then the question is what to do. And everybody gives then saline or any infusion, any fluid. But usually it does not really increase, and you are finished with the procedure before you really can measure again the pressure in the appendage. Really the only way to increase the pressure in the left atrium would be to increase blood pressure. So to give catecholamines in order to raise the blood pressure, and then also the LVEDP, and then the LA pressure would increase. But this is kind of then over sophisticated. So I think it's reasonable to just add 2 millimeters to all your measurements when the LA pressure is too low at the start of the procedure.
Horst, this patient had just mild mitral stenosis, but in the elderly population now with a lot of MAC, we're seeing increasing degrees of mitral stenosis with MAC. What's your limit of moderate or moderate plus before you wouldn't put a LAA in a patient with mitral stenosis?
That's a good discussion. I mean, the only reason why we exclude patients with valvular heart disease from LAA closure is the observation that these patients more frequent have thrombus somewhere else in the left atrial appendage. But I think everybody will agree that clot formation outside of the left atrial appendage in mild mitral stenosis is really very rare. So if you have severe mitral stenosis, that changes everything. But in mild or even moderate mitral stenosis, clot formation outside of the appendage is extremely rare. So I would not have a concern in this patient here.
Sure.
Okay. When you choose the device, the Watchman or AMOLED, and the Watchman Flex, which factor do you usually consider?
Well, really the old Watchman is out. So nobody is using it anymore here in Germany as soon as the hospital is approved for the Watchman Flex, because we have so many advantages. It's atraumatic, you have different implantation techniques, you can start actually outside of the appendage, form the ball, advance the entire thing into the appendage. You have more covering with fabric, you have better hooks, you can retrieve and reposition it as we have shown here. You have better, you have the screw where the delivery cable is going in is covered by fabric. So there are so many advantages. I think the old Watchman Flex is not really of interest anymore as soon as it becomes available in your areas. When you compare the AMOLED with the Watchman Flex, I think it's extremely rare that you have an appendage which can be closed only by one of these devices. So they are really both good devices. In the past, the AMOLED had the advantage that in the case of a short landing zone, when you have a bilobed appendage with short functional length, then the AMOLED had an advantage. But because the Watchman Flex also is shorter than the old Watchman, that advantage has gone away. So that's not important difference anymore. So I think, yeah, both devices are good devices and can be used for probably 98% of all appendages. Then there's the lumbar device, as you know, and it's available in some of your countries. That has some advantages compared to the other devices, and that is there is a special design available where you can place the distal part of the device in one of the lobes and still have a big cover to cover the entire orifice. So this is the special design what lumbar has. So this sometimes there are cases which can be closed only with a lumbar device. Yeah. So any other? There's a principal difference between two-part devices like lumbar and AMOLED and ball design, and that is with AMOLED as well as with lumbar. Sometimes you have a gap between the disc which is covering the orifice and the distal part, they have different names for this, so I'm trying to describe it that way. Sometimes there's a gap between these two parts of the device, and nobody really knows what these gaps mean. And those who prefer amulet or lumbre, they say these gaps are not important, whereas those who prefer really the Watchman, they say these gaps may be important. So we don't know that. And actually, this is one of the difficulties why the definition of residual leaks is not so clear, because the Watchman group of people say everything which is going distally is a leak, whereas the amulet and lumbre people say, well, a leak is only when the flow goes really to the distal part of the appendage. And if there is just a gap between these two parts of the device, that's not considered to be a residual leak. So this is kind of something where we need more data or more studies to really say how important this is.
Horst, well, do you follow patients up at 45 days, like in the previous Watchmans with a TOE, if you have full closure?
Yeah, we do our TE since we started doing LAA closure before the Protect AF trial. We do our TE after 4 weeks, but that's not a big difference whether you do it after 4 weeks or 6 weeks.
Or 6
not
weeks,
so important. So we do it after 4 weeks, and then we do another TE after 6 months. And we do both of these TEs not only to look for residual leak, but also for thrombus. And with the issue with thrombus is that really nobody knows what the best time interval is to do these follow-up images. That's our routine since the beginning. Others do it after 3 months, others do it after 1 year. And we believe from our experience also with other devices like ASD or PFO closure that most likely the majority of thrombus occurs, well, within the healing period, which is up to 6 months. So I think it's rare that thrombus develops beyond 6 months, because we assume that at that time all these devices are more or less covered. Yeah. But I mean, we have seen ASD devices and also LAA devices which have not been covered even after 1 year or 2 years. So that's also a field of unknown things. We don't know why it sometimes happens that devices are not fully covered over time.
Okay, we have to move the second lecture. Thank you for your excellent.
Thank you very much.
Thank you.
Thank you, Horst.
Thank you.
Very nice case.
Yeah, nice case.
Thank you. Bye-bye.
Okay, next speaker is Philippe Garot from Institut Jacques Cartier, France. He will give us a talk titled of Combined Multimodal Imaging Modalities and Computer-Based Simulation to Guide Left Atrial Appendage Closure. Please, Dr. Garot.
Thank you very much. Thank you for your kind invitation. It's my pleasure to be here and talk about combined multimodal imaging modalities and computer-based simulation to guide LAA closure. These are my disclosures. So computational modeling of the appendage to guide LAA closure is based on the characteristics of the LAA. You can see here on the left panel the 3D computer model of LAA based on pre-procedural CT scan, which takes into account the mechanical behavior of the different tissues in the model. And you can combine it with the 3D computer model of LAA closure devices with the mechanical behavior of the device into this model. And then by combining the two, you might have a very nice representation of how could behave the device into the appendage of your patient. A second imaging modalities we're using routinely is the MS-CT fusion to the angiogram. As you know, there is no landmark to treat the appendage. Here you can see a sheath with the device into the appendage, but you don't see any landmark on the chest of your patient, and it's really difficult to guide the positioning. You might have echo for sure, but on your screen you don't see anything. So the principle of this is to use the contours of your appendage, of the appendage of your patient, and you superimpose the appendage on the screen, on the large panel, and then you might have a very nice representation. You can see here the sheath into the fossa ovalis and then into the appendage, and you have a very nice representation of what you have in the reality. So just give me opportunity to show you a case-based example of the strategy we're using routinely. This is a patient, 72-year-old, with permanent AF, CHATVASC4, and ASBLOOD4. He had intracranial hemorrhage under NOAC. And this is the CT evaluation of the patient using the Trimancio software. We can see that the mean average diameter of the landing zone we plan for this patient to put an amulet is 18 millimeter and 16.2 by 20.4 millimeters, so quite a small appendage. And we had to test different options using the Philippe simulation technology. You can see here we have tested pre-operatively different options. You have on the top panel left 20 millimeter distal positioning, top panel right is 22 millimeter distal, and bottom panel you have 25 proximal or distal. So you can see how the device behave, how it's compressed. You can see how the ostium is covered by the device. You might have also the distance between the device and the wall, meaning you have the apposition of the device. So for this patient, we plan to do the 22 millimeter amulet implantation. And this is the CT of the patient with the simulated device you can see here. So this is done pre-operatively, pre-procedural, and you can see that we have on the CT the device into the patient at that time. So for this patient, this is the procedure we did. You can see on the screen, on the large panel, we have the LA in red, and we have the device with the compression and the positioning in yellow. And we have here the sheath with the pigtail to the appendage. And this is the device in place in the appendage. You can see here on the left and right panel that the device is in good position with very similar deformation that was planned then by the CT and the simulation. This is the final result for this patient. And final check with contrast injection and occlude delay. So, yeah, so this is another example of another patient and other representations or other drawings of the device and the appendage. You can see here different modalities with the LA and LAA in 3D volume with the device as it is simulated before the procedure. And this is a different rendering, 3D rendering model of the system that we have. And we're using all of them routinely. You see here, this is before the procedure. We have the device in place. It's just a simulation. It's just a CT and software combination to show how it would be if we put the device in the best estimated position. This is an attempt to treat this patient with a distal positioning compared to what was simulated. You can see here, we are a little bit more distal than simulated. And this is the final position after a recapture and repositioning. And you see that the angle was a little bit different compared to what was simulated, but we are at the good position with a similar rate of compression at that time. So this is the final position we had for this patient that we did a few days ago. So this is our experience, the center experience with the combined use of fusion, CT, and angio, but also with FEOPS simulation technology. As you see, we have done quite 200 patients. We don't have any difference in terms of baseline characteristics and device size, but since we use FEOPS simulation, we have observed that we had decreased procedural time, decreased contrast volume, and decreased X-ray exposure for the patient and the team. So we do think that it's a good tool, and we had very, very good feelings when comparing the FEOPS model preoperatively compared to what we have at 6 months CT. You can see here on the left panel, you have the pre-op model, and we have the 6 months CT with what was achieved. And you can see on this regression that we had a very, very good correlation between what was simulated and what we achieved at 6 months in terms of diameters, perimeters, and areas of the device. So we have started a few months ago a randomized trial. The aim of this trial is to see if the simulation might be of interest in terms of clinical benefit. I mean, we have to randomize 200 patients, make cardiac CT, and randomize to computer-based simulation-assisted left atrial appendage closure compared to standard left atrial appendage closure. And the primary endpoint of the trial is incomplete LAAO closure and DRT at 3 months CT. So we will have the answer of would this technology add something interesting in terms of clinical benefit for the patient. The trial is ongoing. We have more than half of the patient, and end of recruitment will be achieved by the end of the year. So my conclusion is, as you know, LAAO closure might be challenging because of various anatomies and because of the absence of angiographic landmark. It's sometimes a very challenging procedure, as we've seen today with this fantastic case from Frankfurt. And I do believe that the combination of multimodal imaging modalities is very useful to plan the procedure, to simulate what is the best options in terms of device, in terms of sizing, but also in terms of positioning. And it's also very interesting to use that to guide the procedure. Whether this technology is associated with high rates of complete occlusion is a primary endpoint of the PREDICT trial, and we will get this by the end of the year or beginning of next year. Thank you very much for your attention, and I hope you have some question to discuss on this topic.
Okay, thank you for your excellent question. I have one quick question. If there is a huge difference between angiographic measurement and the CT measurement, which imaging modality do you usually trust?
Our experience with CT is now for 10 years approximately, so we are very, very confident with CT measurements. We have some discrepancies, but less and less, I would say, with TEE and angiography. We do not use routinely angiography to size the appendage. We are using only CT and TEE, and we try to have a good correlation between both. But I have to say that we trust more and more CT compared to TEE.
Okay. Is there any comment and question from panelists?
Yes, I have a question. So for the CT, I think there should be a very stringent protocol to see, to make sure the hydrogen status of the patient are all the same, because TE, ultimately, we look at the LA pressure to see this is the correct sizing. We always have problems to tell our radiographer that how to, and sometimes we put in central line to measure the CVP, but it's not practical if this is kind of to generalize to all populations. So can you give us some suggestions how to do a very standardized CT measurement?
Yeah, thank you. Very interesting question. Yes, we had some patients where we of course, as you said, we had hypohydration and patients have smaller appendage than they had. And we recommend to the patients not to be, to eat and drink, of course, before the CT, not to stay like, you know, for general anesthesia, something like that. They have to eat and drink. And in some patients, when we have a doubt, we can put the patient on the supine position to have a better feeling of the appendage. And we have good results. We don't have a lot of problems with this technique and procedure.
Is there any question? Dr. Chiam?
Nothing particular. Very good talk by Dr. Garot.
Okay. Dr. Raffel? No question?
Yeah, there we go. Yeah, just Philippe, the FEOP software and so on, how much time does it take to do the analysis? Is it pretty quick?
It is. It is done by the engineers of the company, so we don't have to do that. And we usually send the CT of the patient the day before the procedure. And we have the results in half a day, I would say. But they have to work online and they have more and more people to work on that. So we have quite, yeah.
And so you pay for that service, do you?
Sorry?
You have to pay for the service that you, with the FEOPS engineers?
Not for the trial.
Not for the trial, of course. Sure.
Okay. Thank you very much. We have to wrap up this session because of time limit. Thank you, Dr. Sievert, Dr. Garot, and all panelists for participating in this session. I hope to see you in person after the COVID-19 outbreak is over. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.